EGAA for inviting me to give this presentation. And I remember the times where we sat in Chicken Tikka in Abbas al-Aqad Street to work on the birth of this society, which became a great society. Dr. Asad Kamel, Ahmed Abd al-Samia, and Dr. Adil Hamid. Last century, shoulder surgery was endorsed by great surgeons as Charles Neal, the first on the left, McLaughlin in the middle, and Carter Rowe, the first on the right. I will review the evolution and share with you my 38 years observation and experience of rotator cuff repair. The evolution of rotator cuff repair started by the gold standard of open transosseous repair through mini-open, then arthroscopic anchor, till the arthroscopic transosseous repair. The first description of rotator cuff tear was by Smith in 1834. The first description of subacromial bursitis was in 1867 by Arabai. Duplay in 1872 reported the term PHS, periarthritis humerus scapularis, which was used for more than 100 years for any shoulder pain disease. In 1934, Codman contributed to major advance in the shoulder surgery. He did the first rotator cuff tear repair in 1909 and recommended early operative treatment. He presented the intrinsic theory of degenerative microtrauma causing cuff tear. He was the first to describe the partial rotator cuff tear. The first to describe subacumal pathology causing tendon tear was Peterson in 1942. McLaughlin in 1944 reported the Mathis suture technique to transosseous cuff repair. Whether the cause of tendon tear was an intrinsic factor or extrinsic factor, my observations was that the high majority was the extrinsic factor. In 1972, Neal described the impingement syndrome as the narrowing of the subacromial space between the tendon and the anterior acromion as the major extrinsic factor. He classified the impingement syndrome into 3 stages: a reversible edema and hemorrhage, stage 1, and the chronic stage 2 of fibrosis and tendinitis, and stage 3 rotator cuff tear. In 1948, Bigliani described the 3 different shapes of anterior acromion related to impingement, but the presence of rotator cuff tear was approximately equal in all 3. With the use of arthroscopy, we classified the space between the anterior acromion and the supraspinatus in 4 types. We did not find in this study, which was done in 1995, a rotator cuff tear in a space more than 1.2 centimeter. Treatment of extrinsic factor causing rotator cuff tears was first done through complete acrominectomy in 1939 by Watson Jones, to lateral acrominectomy, to removal of the anterior acromion, and finally Neal's anterior acromioplasty. In 1983, Neal described the anterior acromioplasty as open wedge resection of the anterior acromion to establish a tunnel and free the rotator cuff from impingement. Historically, open transosseous rotator cuff repair technique, as described by McLaughlin and Neal, can be summarized as follows: end-to-end repair for medial tears, simple transosseous for small and partial tears, simple end-to-end repair for medium-sized tear with mattress repair for crescent and U-shaped large tears, lateral tenodesis of the biceps, and shift of the upper third of the subscapularis and infraspinatus to close the massive tear. Burkhardt described the technique of closing L-shaped tears, anterior and posterior types. Neal used the resection of the lateral acromion to have a better view on the subscapularis, on the supraspinatus tendon for mobilization. The evolution of arthroscopy in treating rotator cuff tears started by positioning the patient in the lateral decubitus position as described by Ellman in 1984. Russell Warren recommended the B-chair position in 1988 with easier free movement of the arm. In 1991, we introduced the sitting position and thus having the advantage of gravity to have a neutral shoulder position as a standard for surgical manipulations. The first arthroscopic subacromial decompression was done and published by Ellman in 1985 using an acromionizer to remove the lower part of the anterior acromion. In 1995, we presented the standard subacromial decompression by using a special measuring needle to measure the anterior acromial cuff space, thus to make it more than 1.2 centimeter as a target for our decompression. Mini open rotator cuff repair with arthroscopic subacromial decompression was described by Levy in 1990. Its disadvantage while treating large tears and postoperative scar formation. Lanny Johnson was the first to make an arthroscopic rotator cuff repair using staples. The technique had its problem of doing a second stage to remove the staple. The first arthroscopic anchor repair was done by Eugene Wolf using the Mitek metal anchor in 1990. Then the train of arthroscopic anchor fixation was developed and propagated using different anchors and techniques by 4 leading surgeons through many years: Wolf, Snyder, Burkhardt, and Esch. The technique was first single row fixation followed by double row fixation to cover the footprint area. Many studies comparing single and double row was summarized by Kim group study, and he claimed that the superiority of double row fixation over single row was 45% less loading gap formation, failure loads, and stress at the anchor site. The other study showed that the stress at anchor site may explain the high rate of recurrence seen in anchor repair. Also studies showed the traditional transosseous technique were superior to single row technique. The study by Bunker in 2011 showed that transosseous rotator cuff repair strength of fusion is like that of the open gold standard transosseous repair. More recent comparison studies between transosseous, single, and double row repair show that transosseous repairs improved ultimate load to failure and reduced gap formation during cyclic loading. The study of Gerber showed that the best repair tendon fixation strength in transosseous fixation compared to single and double row fixation. The summary of all previous studies proved that superiority of arthroscopic transosseous repair over the other repair techniques. The first arthroscopic transosseous rotator cuff repair was done in our hospital in Bonn in 1990 using the giant needle technique. In 2006, the transosseous equivalent technique using the ankles was described by T-Bone. Castanger Group in 2012 presented the Taylor stitch transosseous repair technique. Other transosseous techniques were published as that ACL guide by Lou, the curved passer by Bichon in 2007. In 2018, Castanger reported a comparison study of all transosseous arthroscopic techniques and found that the most effective and easy use technique was the giant needle and the Taylor stitch technique. The next challenge in the evolution of rotator cuff tear is the removing of anchors after failed rotator cuff repair. A loose anchor is easy to remove. After dealing with many recurrent anchor tendon repairs, we found that by using an awl to make holes around the anchor to loosen it is the best way of its removal. Then after removal of the anchors, we do an end-to-end repair and then a transosseous repair using the giant needle and try to have benefit of the still present bone. I want to thank the early pioneers of open joint surgery, first done more than 1,000 years ago by the great Al-Zahrawi, known as Abu Qasis from Cordoba. And I want to thank you for your future efforts in the evolution of rotator cuff repair. Thank you very much for your attention.